Hi, good morning students. Today's class we see about the extend transfusion. Extend transfusion involves removing of the patient's blood and replacing with donor blood in order to remove abnormal blood components and circulating toxins while maintaining adequate circulating blood volume. It is primarily performed to remove antibodies and excess bilirubin in autoimmune disease. The incidence of extend transfusion is decreasing secondary to this prevention, improved perinatal management of alloimmunehaemolytic disease and improvements in the management of neonatal hyperbilirubinemia. Indications: alloimmunehaemolytic disease of the newborn, remove the circulating bilirubin to reduce levels and prevent kernicterus, replace antibody-coated red cells with antigen-negative red cells. Severe hyperbilirubinemia secondary to alloimmunehaemolytic disease of the newborn is the most common reason for extend transfusion in the neonatal intensive care unit. Second, significant unconjugated hyperbilirubinemia with the risk of kernicterus due to any cause when intensive phototherapy is unsuccessful. Severe anemia, that means where there is a normal or increased circulating blood volume, antibodies in the maternal and autoimmune disease, polycythemia, and severe disturbance of blood chemistry. Total bilirubin level at or above the extend transfusion level should be considered a medical emergency, and intensive phototherapy with multiple lights should be commenced immediately. A consultant neonatologist on service should be contacted without delay. Levels in the first 24 hours are less certain due to wide range of clinical circumstances and a range of response to phototherapy. Immediate extend transfusion is recommended in infants showing signs of acute bilirubin encephalopathy or total serum bilirubin is more than 85 micromol per liter above these levels. Risk factors include alloimmunehaemolytic disease, G6PD deficiency, asphyxia, significant lethargy, temperature instability, sepsis, and acidosis. A total serum bilirubin, and if total serum bilirubin does not decrease or continues to rise despite of intensive phototherapy, treatment suggests the presence of hemolysis. Final decision to perform extend transfusions will be made by consultant neonatologist on service will be based on above guidelines as well as the following: trend of serum bilirubin levels and response to the treatment, clinical presentation of the infant, that means the signs of bilirubin encephalopathy. Third one, underlying conditions for previous treatment at referring hospital if applicable, including in utero management of underlying condition. Blood volume. The blood volume for extend transfusion is calculated by using estimate of neonatal circulating blood volume. In term infants, it is around 80 ml per kg, and preterm infants, it is around 100 ml per kg. Double volume extend transfusion, most commonly used for removal of bilirubin and antibodies, 2 into circulating blood volume. For example, the term infant, that means 2 into 80 ml per kg, that means 160 ml per kg. It replaces approximately 85% of blood volume. This will cause an approximate reduction of 50% of pre-exchange bilirubin level, but can be expected to rebound 4 hours post-transfusion to the approximately 2/3 of pre-exchange level. Single volume means 1 into circulating blood volume. For example, it is term infant, it is 80 ml per kg. It replaces nearly 60% of blood volume. Consider when etiology is not hemolytic disease of the newborn. Partial extend transfusion for polycythemia means using normal saline. When desired hematocrit following extend transfusion is 0.55, the volume of exchange, that means in ml, is calculated by actual hematocrit minus desired hematocrit, means multiplies infant's blood volume divided by actual hematocrit. Blood product. Ensure appropriate samples of pre-transfusion testing are sent to the RCH Blood Bank as early as possible. Notify the blood bank via telephone as soon as possible after decision is made to exchange, and order appropriate volumes of blood for exchange. Order fresh frozen plasma for transfusion midway through at and completion of exchange. Appropriate red cells for exchange will be provided by the blood bank. Blood for extend transfusion should meet the following high criteria: have non-hematocrit of 0.5 to 0.6, appropriate group based on infants and maternal blood group and antibodies, negative for antigen determined by maternal antibodies, leukocyte depleted, irradiative and used within 24 hours of irradiation, CMV negative, as fresh as possible, ensure at least 5 days old. Complications. The most commonly reported adverse events during or soon after extend transfusion is catheter related problems like air emboli, thrombosis, and hemorrhage. Hemodynamic include excess removal of injection of blood, hypo or hypertension, intraventricular hemorrhage, hypo or hyperglycemia, hypocalcemia, hyperkalemia, and acidemia. Potential complications related to extended transfusion include arrhythmia, bradycardia, neutropenia, dilutional coagulopathy, feed intolerance, necrotizing enterocolitis, septicemia, bloodborne infections, hypo or hyperthermia. Preparation for the infant. The medical staff should discuss the procedure with the parents or guardian and obtain a consent. Advise consultant neonatologist on duty as soon as decision to extend is made. Exclusively allocate at least one doctor and one nurse to care of the infant throughout the procedure. When extended transfusion is taking place, the consultant neonatologist on duty should be present on the unit to provide support and troubleshoot issues so that the fellow or registrar can carry out the procedure without interruption. Ensure resuscitation equipment and medications are easily accessible. Nurse infant under the radiant warmer for accessibility. Ensure the infant is comfortable and settled. Sedation and pain relief are not usually recommended unless the infant is active and likely to compromise the line stability or sterile field. Ensure full cardiorespiratory monitoring is initiated and document full set of baseline observations like temperature, respiratory and heart rate, blood pressure, and oxygenation. Infant should be nil orally as soon as the decision is made to perform extended transfusion. Pass oronastric tube to aspirate the stomach content. Leave tube in situ for free drainage for duration of procedure. Before commencing extended transfusion, collect blood samples for required baseline blood and any specific testing required. The tests include blood cultures, blood gas, serum bilirubin, blood glucose, FBC, UEC, LFT, newborn screening test, hematological, chromosomal, and metabolic studies. Establish a vascular access for procedure if not already in situ, depending on whether the procedure will be performed via arterial or venous access or via single venous access. Extended transfusion should be performed slowly over approximately 2 hours. Avoid major fluctuations in blood pressure. Anticipate the need for increased oxygen requirement during the procedure via nasal cannula in self-ventilating babies if required. Set blood warmer at 41 degrees Celsius. The blood warming extension should be threaded into the blood warming coil while it is not printed. Using aseptic technique, connect the blood administration set to the blood warming coil and clamp off the lines. Insert administration set spike into the bag of red cells. Release the clamp and prime the line. Clamp off the lines, maintain the sterility of the end of the line. Strict aseptic technique should be maintained throughout the procedure. Record the baseline observations like infant temperature, heart rate, respiratory rate, blood pressure, oxygen requirement, oxygen saturations, neurological status prior to the commencement of the procedure. 2 medical officers will perform the extended transfusion using arterial or venous line. One of them who experience in this procedure. A registered nurse may assist the experienced medical officer if a second medical officer is unavailable. One medical officer may perform extended transfusion using one one line technique. Second medical officer or experienced registered nurse should be available to assist as required. A small amount of blood is extended at a slower rate and usually better to tolerate by infants with cardiovascular instability. A guide at the time for each in and out should be around 5 to 10 minutes. Withdrawal and infusion of blood should be performed at the same rate. In and out amount of blood are repeated sequentially until the desired volume of exchange is reached. In and out amount of blood should be called out so that the nurse recording the procedure can keep accurate tally. Registered nurse should observe the infant throughout the extended transfusion and record following on the extended transfusion record sheet. Volume of blood withdrawn and injected at the end of each cycle. The infant temperature, heart rate, respiratory rate, blood pressure, oxygen requirement, oxygen saturations, blood warmer temperature, general condition of the infant every 15 minutes. If phototherapy lights remain on during the procedure, they should be turned off frequently to assess infant color and general condition. Observe infant for clinical signs of complications of extended transfusion. Administration of medication as required. Routine observation should continue to be recorded in the NICU observation chart as per the standard procedures. After each 100 ml of blood exchange, flush the line with 0.59% of sodium chloride. Administer 1 ml of 10% calcium gluconate by slow push following 0.9% of sodium chloride flush. A calcium gluconate should not come into direct contact with donor blood cells or clotting may occur. Monitor for changes in heart rate and rhythm during the calcium gluconate administration. The last withdrawal volume should be safe for post-exchange blood results. Cease the exchange transfusion if the infant condition suddenly deteriorates. If the exchange transfusion is ceased for any reason, always leave the infant blood volume in balance. Sudden deterioration of the infant's condition may be related to the procedure, underlying conditions, or an adverse reaction to the transfusion. A transfusion adverse reaction report should be made. Post-procedure care of the infant. Continuously monitor the vital signs and record 30 minutes for the first 4 hours post-procedure. If stable, after this time, routine observations as per an NICF observation chart should be continued. Perform blood glucose levels immediately post-procedure and then hourly until stable. Measure serum bilirubin levels on 1 hour post-exchange transfusion and repeat 6 hourly. Continue phototherapy until bilirubin levels are within acceptable range. Anticipate rebound increase in serum bilirubin 2 to 4 hours post-procedure. Observe catheter sites for signs of bleeding, as exchange transfusion carries a potential risk of necrotizing enterocolitis. Especially in preterm infants, monitor the appearance of abdomen and presence of the bowel sounds. Observe for signs of feed intolerance when feeding is recommended. Measure urea and electrolytes, full blood examination, hematocrit, blood gas on regular basis until the infant is stable. A medical officer performing the exchange transfusion should document the procedure in the progress note. Thank you for listening.